Thank you, sir. It's a privilege and an honor to be here in such hallowed presence, and I don't deserve more than two-thirds of the things you said about me. It was a little over, but thank you. It's a privilege to be there. So my talk would be on, because I believe that we should not just blindly emulate what the Caucasian world is doing, but try to fit our surgical skills according to what our society, our country needs. And this is a picture of how the fishing network works there, and just with a mild modification, how it works extremely well in our setup. So you should not be charmed by newness, as Dr. Manyar said, and as Dr. Nagpal has always told us, that have a scientific foundation to whatever new practice comes. Old and time-tested often is still relevant, so keep a societal perspective. And therefore, this course was designed with Dr. Manyar just to relearn some older relevant skills. This will be I'll be showing just 4-5 videos of 1 minute or 1.5 minutes each. I'm sorry. This was a patient, can you just switch it off, please? I'm sorry. This is a patient of a manual SICS fracture, because initially we didn't have a phaco machine and we wanted to give the benefit to our patient, and I started doing this surgery. And I found that this surgery was pretty much doable, and contrary to what I thought, it was not leaving much of a reaction. So this was how my journey to SICS trap started, with the phaco fracture or the SICS fracture. So this video is little self-explanatory. I've put a foldable lens through this was not a 3.2 incision, of course, because it required the nucleus to be brought out. It was a so you can see the section is 4 millimeters, and through that you've been able to do a surgery, and this is the post-op day 1. Believe me, it is true that you can do this surgery pretty comfortably. Therefore, having this, we started doing it because I have a lot of glaucoma in my patients. So with IFO patients in which phaco either was not available or was not possible, the patient couldn't afford a foldable lens. Okay, then why can't we give him an equivalent result as a phaco trap? And that is when the 6th trap was born. The W construction of the incision. So that's the W-shaped incision being constructed. This was a very old surgery. I have not tried to edit too much. We used stretching because we didn't have the iris hooks available. So you can manage without many innovations with the older skills and still do a good job. This is a grade 3 hard nucleus. I have prolapsed it into the anterior chamber, and with a simple vectors and a sandwich technique, I prefer that because I do under viscoelastic cover. At no time is the anterior chamber lost, which is the basis of any trap if you want to have a less inflammation post-op and prevent decompression retinopathy. And do a punch. Again, the AC at any time is not being lost, anterior chamber is maintained. A large, generous PI. Glaucoma surgeons are very generous with their incisions, unlike cataract surgeons who are very stingy with their incisions. So I always use Wilson's technique of releasable suture, which is not the topic of today, so I will not be covering that, but that's what I've been doing. 2 releasable sutures and 2 non-releasable fixed sutures, and amniotic membrane at the end, and then a suturing. I will show the suturing separately. So this is the way it's done. Inner sclerostomy is created with a very controlled manner, and a punch technique is used. The suturing is very meticulous, and the corneal end of releasable suture is there, and there are two non-releasable sutures. This is a short video of how the suturing has to be done. At the end, you will just do 2 bleb forming sutures with 8-0 nylon because they need to be more strong. So and then you are doing just a simple, very simple horizontal mattress sutures. Please avoid the releasable sutures at this stage. And you will find at the end, when I do a bleb titration, the wound is pretty secure. Touch wood, we haven't had too many bleb leaks. We've been doing this technique over now almost more than a decade. All our residents are very familiar with it. So in case the phaco machine conks off, in case something happens, you don't have a phaco, you are in the camp or wherever, you can deliver as well with a 6 trap or a 6 phaco fracture. And this is the sequence of patients. This is almost a 5-year follow-up of a patient who is doing well without any secondary medications. And these are the post-op patients of 1 or 2 patients, patient 1 and patient 2. The bleb is pretty nice. This is another scenario in which phaco would never be feasible, a very dense corneal opacity. Mostly people would just go in to do an ECC trap, but ECC trap has a lot of suturing required, the bleb failure is higher, patients are more uncomfortable, and the surgical time also is large because you need a lot of suturing. So 6 trap doesn't take more than 30 minutes and it gives you a good bleb. You just need to remove the sutures after 1 month. They are the horizontal mattress sutures, I do it on the slit lamp only, and the releasable sutures as and when required depending on the bleb. So this is the triangular flap has been made, and I'm just trying to prolapse because the visibility is very poor in this. So you're just trying to prolapse the nucleus out of this. It's a visco-assisted because thankfully the nucleus wasn't very hard in this scenario. And the same way I just do a PI and the suturing. So then this last thing which we just started doing around a year ago, we're compiling our data. I call it the smile incision because a lot of our patients have a re-surgery and the bleb is that area of the limbus is scarred. So when we do a repeat surgery, it's a 6 trap, or this was not a 6 trap, this was a repeat trap, and you either need to do a tube or you have to stagger it on the nasal side or the temporal side. So what we do is just modify it and leave a frill of conjunctiva. This is an AC maintainer in because it is an IUL capture, so I don't want the AC to collapse on during table. And while punching, you can see that a lot of fibrosis was there. Another new thing, very simple modification is amniotic membrane. The implants and the tube shunts are very expensive. They're not very cost effective in the scenario where the patients can't afford. So we asked 3-4 patients to club together and buy amnion. It cost them that way 500 rupees. And I create holes, penetration in the amniotic membrane, because we find over the time that amniotic was giving rise to little tenon cyst formation. And this, again, I've been using amniotic now for more than 15 years. It is working beautifully. The blebs are very nice, quiet. It dissolves within 1 to 2 months, in fact lesser time, and gives a very quiet, nice bleb. And this is the continuous suturing, running suture, which you have at the end, and the patients are very comfortable with this. The suture is removed once at around 1 month. So this is the post-op day 1 and post-op 6 months, a very quiet eye. This is another patient with AMT with implant, again the same technique of smile. So judged by Dr. Manyard at the altar of utility, functionality, quality, cost effectiveness and time, I believe 6 trap and the modification of 6 and the smile incision would stand the test of time over any new fangled ones. So old is solid, it lasts. Dr. Nagpal is a living testimony that everything which is old is amazingly gold. And we are also growing old, but we need to remember this is a small message out of the box that we need visual images like this, we need scenes like this, we need it for posterity. However, we are the intelligentsia. Doctors in India are the intelligentsia. We are blessed by God that we've achieved this level. We need to bless our fellow men also by trying to avoid unnecessary plastic so that sites like this remain. Please reduce use of plastic, unnecessary plastic. Let us leave drinkable water for our children, breathable air for our grandchildren, and seeable sites like this for posterity. Thank you for the opportunity.